Hi, today my colleague Aya Saleh and I, Sarah, will be talking about a case of respiratory distress syndrome that we encountered during our clinical rotations. This is our table of contents. This case involves an infant who presented with respiratory distress syndrome requiring escalating respiratory support. The management involved a combination of non-invasive respiratory support, surfactant therapy, intubation, and mechanical ventilation, which provides key insights into neonatal respiratory management. This case is particularly interesting because it demonstrates the role of advanced respiratory support techniques, use of surfactant therapy, as well as the importance of careful monitoring and titration of mechanical ventilation settings to promote optimal outcomes. The clinical decision-making process, including the evaluation of oxygenation needs, radiological findings, and treatment escalation, is also of particular interest in this case. The baby was delivered via lower segment cesarean section due to a history of previous cesarean. The baby was born vigorous, requiring no active resuscitation, and had UPGAR scores of 9 at 1 minute and 10 at 5 minutes, suggesting good adaptation to extrauterine life. The breakdown of the UPGAR score shows that at 1 minute, the only deduction was for color, 1 point, while all other parameters such as respiration, heart rate, grimace, and tone were 2 points. By 5 minutes, the baby achieved a perfect score of 10. Additionally, the cord blood gas was normal, further confirming the baby's stable condition at birth. The baby is at 36 weeks plus 4 days, considered a late preterm. At admission, the baby was 3 hours old, weighing 2.73 kg. The date of birth was 2/1/2025. The baby is of Algerian nationality and height was not recorded in the available data. The baby was admitted on 2/1/2025 due to respiratory distress, presenting with grunting, retractions, persistent tachypnea, and desaturation shortly after birth. Given these symptoms, the baby was transferred to TCNU for high-flow nasal cannula therapy to provide respiratory support and prevent further deterioration.
The diagnosis of respiratory distress syndrome was confirmed through a combination of clinical presentation, imaging finding, and blood gas analysis, all of which strongly indicated surfactant deficiency and impaired lung function. Within an hour of the birth, the neonatal exhibited tachypnea, grunting, subcostal retraction, and desaturation, which are classic signs of neonatal respiratory distress. Initially, high flow nasal cannula at 3 liters per minute with 30% FiO2 was used to provide respiratory support, but the baby's condition continued to worsen with increased oxygen requirements exceeding 45% FiO2. The need for high oxygen concentration and persistence of respiratory distress, despite non-invasive support, suggested an underlying issue with the lung compliance, which is hallmark of RDS due to surfactant deficiency. To further assess the condition, a chest X-ray was performed which revealed ground glass opacities, mild lung inflation, and air bronchograms. These radiographic findings are strongly indicative of RDS as they reflect alveolar collapse and poor aeration due to insufficient surfactant production.
Maternal history. Gestational diabetes which was managed with metformin and insulin during pregnancy, gravida of 5, para of 3, elective caesarean section due to previous caesarean section, neonatal history, no significant complications at birth.
In differential diagnosis. So, to determine the cause of the baby's respiratory distress, neonatal pneumonia was considered, as it can present within the first 24 to 48 hours of life, just like RDS. The baby developed tachypnea, grunting, subcostal retraction, and increased FiO2 requirement shortly after birth, which are symptoms seen in both pneumonia and RDS. And due to possibility of neonatal sepsis or pneumonia, the babies with the worsening respiratory distress are often started on antibiotic until the infection is ruled out. So in this case, there was initial concern for infection, so the neonatal pneumonia had to be considered. And the GPS screen was negative, reducing the risk of bacterial pneumonia. And CRP remained less than 2, making the bacteria infection unlikely. And the blood cultures were negative, confirming that there was no systemic infection or bacteria. And the antibiotics were discontinued after the 48-hour because there was no evidence of infection, and further confirming that the pneumonia were not the cause of respiratory distress.
Chronological medical management day 1. The baby was born vigorous, requiring no resuscitation with Apgar scores of 9 at 1 minute and 10 at 5 minutes. However, shortly after birth, the baby developed tachypnea with desaturations down to the 80s, requiring free flow oxygen for 1 hour. Due to persistent respiratory distress, the baby was transferred to TCNU and placed on high flow nasal cannula at 3 liters per minute with FiO2 of 30%. Despite this, the baby continued to exhibit audible grunting, tachypnea, and retractions, prompting an escalation to CPAP of 6, FiO2 40%. However, within an hour, FiO2 requirements increased from 45 to 50% with fluctuating oxygen saturation levels of 91%, raising concerns for worsening respiratory distress. A chest X-ray confirmed features of RDS with 10th rib inflation, but negative for air leak. Consideration for LISA due to high FiO2 requirements and respiratory distress. LISA technique. LISA stands for Less Invasive Surfactant Administration. Instead of traditional endotracheal intubation and mechanical ventilation, surfactant is administered through a thin catheter. This approach helps to maintain spontaneous breathing, reducing the need for prolonged mechanical ventilation and its associated complications. A systematic review and meta-analysis research study by Silveria and others in 2023 found that LISA significantly reduces the need for mechanical ventilation, lowers the risk of bronchopulmonary dysplasia, and decreases complications such as pneumothorax and severe intraventricular hemorrhage. In our patient, LISA allowed effective surfactant delivery while maintaining spontaneous breathing, helping to avoid prolonged intubation and mechanical ventilation. A capillary blood gas showed uncompensated respiratory acidosis. Given the high oxygen requirement and worsening distress, the team decided to shift the baby to an IV first. 18 over 16 centimeters of water being sprayed over the PEEP, TI 0.50 seconds, RR 40, FiO2 44%. Despite this, the FiO2 demand remained high, and a decision was made to administer surfactant using the LISA technique. The procedure was well tolerated, with 8 mL of Survanta delivered slowly over 2 minutes, and FiO2 was successfully weaned to 40% post-procedure. This is a chest X-ray of RDS. It is an AP view. It shows good exposure, the vertebrae are shown, good rotation, good inflation, 10 posterior ribs, NG tube is present and it sits in the stomach, and you have ground glass appearance. Baby was noted to have mild subcostal retractions. A follow-up chest X-ray revealed a pneumomediastinum, though the baby continued to maintain oxygen saturation well at that point. However, as the clinical course progressed, the baby became agitated with increased work of breathing, and FiO2 requirements escalated to more than 50%, indicating worsening respiratory distress. Given the increased work of breathing and oxygen demand, the team decided to intubate the baby. A 3.5 mm endotracheal tube was inserted at 9 cm upper lip level with proper position confirmation by auscultation, CO2 detector, and chest X-ray. After confirming placement, the ETT was advanced to 9.5 cm upper lip level, positioning it at T2 level on the chest X-ray. The baby was then placed on assist control ventilation with volume guarantee, ACVG, at 5 mL per kg, which is 13.6 mL total for a 2.73 kg weight. With an RR of 40, TI of 0.35 seconds, pressures of 25 over 5.5 at FiO2 of 80%. Despite this, the baby utilized all the set pressures to achieve the target tidal volume with a mean airway pressure ranging from 13 to 16, indicating ongoing lung stiffness and poor compliance. The VG setting was reduced to 4.5 mL per kg, which is 12.3 mL total, and FiO2 was successfully weaned to 50%. A follow-up blood gas showed a normal CBG reflecting adequate ventilation and gas exchange. Chest X-ray reveals pneumomediastinum and ETT at the T2 level.
On day 3, the baby remained intubated with the ET tube size 3.5 and secured at 9.5 cm and continue on the ACVG mode with a tidal volume 4.5 mL per kg. And due to desaturation avoided during the routine care, the Bmax was increased to 28 cm of water and the Beep to 6 cm of water to improve oxygenation and lung recruitment. And blood gas analysis pH 7.32 and BCO2 46 indicate stable ventilation, so the team decided to continue the current support rather than administering a second dose of surfactant and focus on monitoring and weaning opportunities. In the day 4, the baby showed gradual improvement and the ventilator settings were adjusted. The Bmax increased to 28 with a beep of 6 cm of water with the pressure range from 24 to 30 cm of water to achieve the target tidal volume 4.5 mL per kg and the mean airway pressure of 11 to 13 cm of water. The FiO2 was successfully lowered from 60 to 30% and the baby's work of breathing improved with fewer desaturation episodes during routine care. A capillary blood gas was taken in the morning, the pH 7.33, the BCO2 46, the bicarb 24.3, with the p-axis -2. Which indicate uncompensated respiratory acidosis, also indicate mild improvement in the acid and base state comparing to the previous blood gas. And an echocardiogram done showed no sign of pulmonary hypertension and minimal tricapside regurgitation. During the round, the team planned to reduce the sedation and assess for possible extubation the following day if the baby was stable. Move on to the next day. On day 5, the FiO2 was initially weaned between 21 and 23%, with the baby requiring pressure of 24 to 25 cm of water, and MAP of 9 to 11 cm of water to maintain adequate ventilation. And pre-extubation blood gas showed the pH 7.44, BCO2 35, bicarb 24.6, p-axis 0.2, which indicate normal blood gas and stable ventilation and readiness for a spontaneous breathing trial. So the first SPT trial failed in 1 minute due to 3 events of bradycardia, desaturation, and apnea. However, after 1 hour, the second SPT was successful despite mild tachypnea, with FiO2 reaching 30%. Then the baby was extubated to the CPAP of 6 cm of water and FiO2 35% via RAM cannula. Then due to persistent tachypnea, the CPAP was adjusted to the mask with the 7 cm of water. Then post-extubation blood gas showed the pH 7.37, the BCO2 38, the bicarb 22.4, the p-axis -2.9, which are in an acceptable range and indicate a stable ventilation and no significant respiratory acidosis. Finally, a last chest X-ray after extubation showed improved lung aeration and good lung inflation up to the 9 rep, and less infiltrate compared to the previous image, and there were no sign of consolidation, and the secretion appeared reduced and manageable, and these findings indicate better lung recruitment and ventilation aligned with the baby's clinical improvement. So close monitoring after extubation essential, especially through blood gas analysis to assess if the baby can tolerate further weaning.
This case highlights the importance of early recognition and stepwise management of neonatal RDS, Several key interventions were crucial to the patient's successful recovery. Early CPAP and IV helped maintain lung recruitment, reducing the need for immediate intubation. The LISA technique for surfactant administration allowed for improved oxygenation while maintaining spontaneous breathing, lowering the risks associated with prolonged mechanical ventilation. Pneumomediastinum was managed conservatively as it often resolved with careful ventilation adjustments. The extubation process was guided by SPTs, ensuring the neonate was ready for weaning before transitioning back to CPAP. From a clinical learning perspective, this case highlights that decisions should be based on clinical progression, ABG trends, and image findings rather than just FIT requirements alone. Additionally, teamwork between doctors, respiratory therapists, and the nursing staff played a vital role in optimizing the care and achieving a successful outcome.